like to invite Dr. John Kanellopoulos for his talk on management of anterior stromal scarring with laser.
Good evening, almost. Thanks so much for staying so long, and thank you for having me here. So we're going to see some alternatives on treating significant cornea scarring as the one we're seeing here without a penetrating keratoplasty. I do have financial disclosures with some of the products I'll be discussing, mainly the laser platform by Alcon. And the key points in treating a anteriorly scarred cornea is, in my opinion, in my experience, whether you're going to use mitomycin C as an adjunct, whether you're going to use CXL, cornea cross-linking, as an adjunct, because some of these corneas are thin, number one. Number two, some envision CXL as a way to modulate keratocite activity after an extramural ablation, and how much of the refractive area you're going to treat. And there's not much in the literature that has been published on this point. We're going to be discussing some of these customized techniques that are off-label in the U.S. They're on-label in Europe because topography-guided was initially introduced in Europe in 2003 to treat irregular eyes, so they're within the context of treatment. And it so happens that last month at the ESCRS, we had a paper looking at 15 eyes with post-contact lens-related infections that resulted in significant scarring. We heard some great talks on acanthamoeba this morning that we tackled with a topography-guided surface ablation with adjunct CXL and relatively good success. We're seeing an example here on the top before and after, and the OCT images here before and after. There's still some residual scar left, but there's significant improvement. For me personally, this is a very long journey. It's been many years since I was in a similar podium here at the Academy, and we talked about using topography-guided techniques in treating different difficulties in the cornea, enlarging an optical zone. This bottom image is a herpetic scar that we had treated back then, and this was published at the Journal of Refractive Surgery as well as Journal of Cornea later. And this was the handout. It has almost historic value from 2007, how to manage significant distorted corneas. But I think for many of you, the Journal of Cornea review editorial that I put together looking into how to treat irregular corneas such as keratoconic corneas, and I included literature from researchers throughout the world, gives you an idea how topography-guided can, for instance, in a irregularity such as keratoconus, treat, as we're seeing here on the top right, with two irregular ablation profiles, and this is with refraction set at 0 in an attempt to reshape the cornea and normalize the cornea. And we're seeing on the bottom how a very regular cornea becomes very regular in the middle, and the difference underlines the accuracy of this treatment in flattening the cornea. The difficulty, though, with cornea scars is that the ablation of scar tissue is relatively unpredictable. Number one, in clinical reality, the accuracy of measuring the pachymetry of the cornea is also significantly biased, definitely by sign fluke technology, which gets very confused of the opaque cornea in anterior segment scars, in OCT imaging as well. This would be an ideal technology to use. It just became FDA approved. We have been using it in Europe since 2019. And ray tracing includes topography-guided and wavefront data along with actual length data, and can treat the irregularity of the cornea as well as the refractive error as well. And I'm going to go through some examples here. For instance, this is that acanthamoeba contact lens related scar. By the way, it was treated with monotherapy in London for a while, and then double therapy, but very late steroids were employed. And this would be the topography-guided treatment plan for this cornea with placido disc topography if you set refraction for 0. So we're seeing here an attempt to take the placido disc image here of the cornea, apply this treatment here, which will steepen the central flattened area, and this is the post-op result, which is a far more normalized cornea. And we can see that in this process, significant part of the cornea scarring is removed as well. As I mentioned before, the risk here is always going too deep and creating a very thin and a cornea that may go into ectasia. This again in the before and after. We saw that case before, and how the cornea scar has diminished enough for the patient to attain relatively good vision. And these are two other examples, and I will just stay with a treatment plan here and here on how you can tackle some of these quite difficult cases prior to considering a anterior lamellar keratoplasty technique. In some of the cases that I expect the cornea to be very thin, employ accelerated CXL. But again, as I mentioned before, thickness measurements can be elusive. So in conclusion, this is a valid toolbox for you to manage these cases. Treating the refractive error is very elusive. Reducing the irregular astigmatism is probably a realistic goal, along with removing as much as the anterior scarring as you can, and thus, in most of these cases, be able to have a good result. Thank you very much.